thanks everyone for joining us today. So I thought what I would try and do today is tell you a little bit about what we as epidemiologists know currently about autism spectrum disorders and what kinds of risk factors we are in the process of investigating through the study that I will talk about a little bit later, the study to explore early development, and also many, many other studies that are going on in this country and around the world to try and understand this disorder. So first of all, I want to just give you a little bit of background about the prevalence of autism. So if you look back in the 60s, in the 1960s, the estimated prevalence was around 7 per 10,000. So we really didn't see this very often. We didn't diagnose it very often. We began to see a rise in the prevalence in the early 2000s. You see a study done in the U.S. in 2003 where we were reporting now a prevalence of 34 per 10,000 or 3 per 1,000. And we have been involved now for 10 years with the CDC in monitoring the prevalence. And our most recent data that just came out in 2011 indicates that the prevalence is about 1%. So about 1 in 100 individuals carry this diagnosis. So the question I often get asked as an epidemiologist is this an epidemic? And I think to really understand that, we need to look at what the definition of an epidemic includes. So most basically, the definition says it's an increase in the occurrence of new cases of disease beyond what's expected.
I'm sorry, there's down.
So, I'm sorry, there's background talking. If you can try and mute your phone.
Yeah, I'm sorry. If everyone could try to mute themselves. I'm attempting to do it myself, but again, this is the first time we're using this technology. So if you are on a phone or even if you're have computer speakers, if you can make sure that they're muted, that would be very helpful so that we could all hear we can all hear the presentation. I'm sorry about that. Go ahead.
That's all right. All right, so epidemic, it's increase in the occurrence of new cases of a disease or a disorder beyond what is expected. We clearly see that in autism. I mean, it's gone up really dramatically in the last 3 decades. But the important part of the definition is this last part, and that is, in order for something to be an epidemic, it has to be attributable to change in the real risk of disease. In other words, the risk of acquiring the disease has to have gone up in order for something to be an epidemic. So what else could it be if it's not an increase in the risk of acquiring the disease? Well, in the case of autism, it's very likely that it's a function of awareness and also of changes in the diagnostic criteria. So those two things working together could actually be the explanation for the increased prevalence. We don't know for a fact that that's what's going on, but many epidemiologists believe that the lion's share of the increase in prevalence is a function of change in criteria. So the criteria have widened, making it easier to acquire the diagnosis of autism. And awareness has certainly gone up. It's on all the news shows. It's all over the media. Parents, grandparents, teachers, pediatricians, school teachers are all aware of it. So the likelihood of a child coming to recognition and getting a diagnosis is greatly, greatly increased. So those are the things that we're studying as part of our Autism Center. And at the same time, we're also looking for the real risk factors. We know there are risk factors. We don't know exactly what they are. What do we know? Well, this is what we know about the timing of onset. The mean age of diagnosis in the U.S. is 5.5 years, 5.4 years. Now, that doesn't mean that that's the age of onset. That means that's the mean age of diagnosis. We know that autism can be picked up as early as 18 months, 24 months, very reliably, and yet many children go unrecognized until they're in school, until they're in kindergarten. We also know that many children develop normally and then go through what we call a period of regression, and then end up with the label of autism spectrum disorders. You can imagine that these are particularly distressing cases for the families. They have a child that is developing normally, and then that development stops and reverts. So they have language, and then they lose language. This represents about 25% of all cases with autism spectrum disorders. We believe that the etiology for these cases is different. than the cases where the signs and symptoms are there from birth or as early as we can detect them, but we haven't yet figured out what those differences are. One of the really challenging things about autism is that it really presents as absence of typical behavior. It's not, for example, something like attention deficit hyperactivity disorder where the child is acting out, and it's those acting out behaviors that bring the child to attention. What we're looking for here is subtle deficits, so deficits in communication, deficits in social interaction, deficits in interests and behaviors. And these are much harder to pick up than something that jumps right out at you and says, I'm different. These are children that are developing. Maybe they're not developing as quickly as the next child. Because development is a continuum, we may say, well, they'll get there. They'll start talking soon. They'll begin communicating more thoroughly soon. And that's often what parents hear. They hear a wait-and-see approach because development often is a wait-and-see, and then the child develops perfectly normally. The other thing about autism is in order to pick it up, we really need a trained observer. And so the ascertainment of cases is highly dependent on the observer. Someone who's seen a lot of children with autism before is going to be much more likely to be able to pick up a child with autism from a crowd of children. So without trained observers around, it can be something that's missed for months and even years. Okay, what do we know about etiology? What do we know about the cause of autism spectrum disorders? Well, we know that it's a strongly genetic disorder. We also know that it's not a purely genetic disorder. A very interesting paper just came out from Stanford. The lead author is an autism researcher, genetic epidemiologist by the name of Joachim Hallmeyer. And he has a large sample, a very well-characterized sample, and he reports out that the recurrence risk for siblings is about 10%. That's consistent with what we've seen before. But the concordance rates in identical twins, he presents some new information. We used to quote the figure of about 80 to 90% concordance for identical twins. So in other words, if you have a set of identical twins and one has autism, 80 to 90% of the time, the other twin would have autism. It wasn't 100%, but it was very, very high. His estimates, which I think are quite reliable, take that down a little bit and say, no, it's more like 60 to 70% of the time. If one twin has it, the other has it. These are identical twins. So, but think about that. Those are identical twins. They have the same genetic makeup, the same DNA. If it was a purely genetic disorder, the concordance would be 100%. So in the absence of complete concordance, and we now think it's a little less than we did before, environmental factors must be involved and obviously are very important to understand. So we think about it as a genetic susceptibility with an environmental trigger. And what we're investigating now is what are those environmental triggers. We know it runs in families, but we have twins where one gets it and the other doesn't. We have siblings where one gets it and the other doesn't. What are the triggers that cause one child to get it? So some of the risk factors we're looking at relate to the following domains: immune dysfunction or infection, pregnancy, labor and delivery factors, and then other environmental exposures. So I'm going to say a little bit about each of those domains, and those are just 3 domains among many. These are the ones that I think are probably the most important and where the most investigation is going on. So what do we know about immune dysfunction? Well, from laboratory studies of blood from children and adults with autism spectrum disorders and from postmortem studies, we know some interesting things. We know that the cerebral spinal fluid, the CSF, and the peripheral blood from those with autism show markers of dysregulated immune systems. So that's an interesting finding. We also know from postmortem studies that the CNS tissue from individuals with autism has markers of these innate immune system abnormalities. So on a biological basis, we know there are immune system differences in these individuals. When we look epidemiologically, we see some confirmation of these findings. First of all, we see that prenatal exposure to infection, so an infection in the mom while she's pregnant, confers an increased risk for autism to that child. We also know that there is an increased frequency of autoimmune disease among mothers of children with autism spectrum disorders. So again, we have both biological data and epidemiologic data supporting immune dysfunction and immune factors as an important causal pathway in autism. What we don't know is which direction the pathway goes. So, for example, does immune dysfunction during the development of the child, during the child's brain development, lead to some kind of abnormality that then results in autism, or is it an abnormality of the central nervous system that triggers the abnormal immune response? We don't know that yet. We're still in the early stages of describing this relationship. All right, pregnancy and labor and delivery and risk factors are of huge interest for obvious reasons, and there are lots and lots of epidemiologic studies that have been done looking at these. Many of them are small and don't have what we call statistical power to really rule in or rule out risk factors, but there's beginning to be a larger body of well-done studies that are large enough to really rule in or rule out, as I said, these various risk factors. So we know, for example, that advanced maternal age and paternal age at the time of birth of the child confer an independent increased risk. So if the mother is over age 34 and the father is over age 35, there's an increased risk for that child having autism. We know that if a mother has bleeding during her pregnancy, so gestational bleeding we call it, there's an increased risk for that child having autism. We know if the mother has diabetes that begins during her pregnancy, what we call gestational diabetes, that confers an increased risk. We know that there are some prenatal medications that confer an increased risk. We know that babies who are born too early, so preterm delivery, low birth weight babies, have a substantially increased risk. And actually, we have a paper that's just been accepted for publication in Pediatrics where we demonstrated this using our neonatal brain hemorrhage cohort that you heard about earlier. And we were able to show that among that cohort of babies born preterm, there's about a 5-fold increased risk of autism. So again, we don't know what the direction is there. Is it that babies who are born preterm are also at higher risk for autism? Is it something about the baby before it's born? Is it something that happens to the baby after it's delivered in the neonatal intensive care unit? We don't know. We have a lot of work to do, but this finding is being seen by other individuals as well. So this will be an area of great interest. What a lot of studies have done with these pregnancy and labor and delivery factors is put them into an index where any bad thing that happens gives you a point, and the more points you have, the greater your chance of a child with autism. And that's an interesting way to go. It doesn't really help us in terms of understanding the underlying biological mechanism. So we're trying to get away from those kinds of studies and really look individually at risk factor by risk factor. So some other environmental risk factors that we're interested in. We know that there's some prescription medications that have been clearly shown to confer an increased risk of autism. So thalidomide, which was a sedative and an anti-nausea drug given to moms in the 50s for morning sickness primarily, we've looked retrospectively now at data and shown that there's a very strong increased risk of autism among individuals who are exposed to thalidomide during their gestation. Valproic acid is an anti-seizure medication, so if a mother has a seizure disorder, she would often continue to take this medication, and again, we show a substantial increased risk. Finally, misoprostol, which is a drug given for gastric ulcers, it's also used as an abortifacient for late-stage abortions, a labor induction drug, confers an increased risk of autism. So these are 3 that we have very strong data on, and the risks are substantial. There's many, many other drugs that we're interested in and that we're in the process of looking at. You can imagine it's hard to collect that data in a reliable fashion, but we are trying to do so. There was another paper that was recently produced, a very interesting study out of California using the Kaiser database that looked at selective serotonin reuptake inhibitors, SSRIs, antidepressants, and the data suggests that there may be an increased risk for babies who were exposed during their first trimester. This is the only study that's looked at this, and they report the increased risk, but we have to interpret this study with caution, partly because we already know from many other studies that have gone before that familial psychiatric history, so any kind of psychiatric disorder in the family, in the mother or father, in the grandparents, in the cousins, confer an increased risk for autism in the individual child. So there looks to, and that's probably because of genetic load, so we know that there's already an increased risk, and it could well be that this SSRI data is just acting as a marker for the underlying maternal depression, for example, which would confer an increased risk through a genetic mechanism. So these are the kinds of puzzles that we have to tease apart as epidemiologists. We see these findings observationally, and then we have to dig down and say, what does this really mean? We need to see it replicated. We need to see it replicated many times over with lots of attention to the methodology of the study before we'll really say, this looks like a real finding. This is something we really need to pay attention to. We should be, for example, warning women about. We're a long, long way from that at this point. But interesting data anyway. What often happens, unfortunately, is that the media gets a hold of these studies and they put it out as an established fact. SSRIs cause autism. And that is a disservice to everybody concerned, partly because SSRIs are very important for women who are suffering from depression, and also because it sort of diverts our attention away from searching for the cause. And this is what happened with the vaccine controversy. We've spent lots and lots of research time and money and energy debunking the autism vaccine hypothesis, and it still has a toehold. There's still people who believe it and are not vaccinating their children as a result. So I think that the media has to be very careful in how they interpret these studies. We're also interested in the more typical exposures: alcohol, smoking, illicit drugs. These are all things that we're collecting data on in our study, which is this slide here, the Study to Explore Early Development, also known as SEED. This is a multi-site study. It's being conducted by 6 centers across the country. It's funded by the Centers for Disease Control. And the main goals are to investigate risk factors for autism spectrum disorders in children, and then to look at how genes and environment interact to affect the ASD risk. So that's what we started out talking about, that genetic susceptibility and then environmental triggers. SEED study subjects include 3 groups. We will ultimately have about 900 children in each group. The first group is obviously the children with autism spectrum disorders. The second group is a group that we call the neurodevelopmentally impaired control group. So they have a neurodevelopmental disorder, but it's not autism. And then we are also comparing the autism group to a third group, which is just a very typically developing control group. These children are all between 2.5 to 5 years of age, and we bring them into our clinic here at Penn for a full day of evaluation. And we have a wonderful team here that works with the families, collecting data before they come in for the visit and then when they appear for the actual visit. And this study is ongoing. We're probably about 2/3 of the way through of recruitment and enrollment across all the sites. So we don't have results yet, but we will have some very, very powerful and interesting data. And these are some of the domains that we're looking at. We're looking at the broader phenotype. So we know that because it's a genetic disorder, we see traits of autism in other family members. Maybe even without the full diagnosis, we can see characteristics that are part of the autism spectrum in other family members. Again, the infection and immune function domain is of great interest. We're looking at reproductive features, hormonal features, gastrointestinal features. Many of these children suffer from GI disorders, so there's a thought that there's some connection there. Genetic features, sociodemographic features. How does this disorder vary by ethnicity, by economic status, and if it does, why? Pregnancy factors, as we've already discussed, and then other environmental exposures. So that's really it. That's all I wanted to say in terms of the formal presentation, and now I'm more than happy to open it up for discussion and to have some questions.
Great. Well, Dr. Martin, thank you so much for that. That was a great overview of the research that's out there and the work that you're doing. I want to just remind people, I'm going to just go to our next page so people can start entering questions. So if you have any questions at all, please enter them in the Q&A pod. And while we're waiting for your questions to come in, Monica, I was going to turn it over to you because I know you had a couple to start us off with.
Sure. Thanks, Lisa. We do have a couple questions that have come in here. One of the questions that we have, Dr. Pinto-Martin, starting with looking at the gap that you showed us where a number of children can be diagnosed as early as, I think you said 1.5, at the age of 1.5, but for many, the mean age in the U.S. is about 5.5 years. Can you talk a little bit about why that gap in diagnosis is happening and what's being done about it?
Yeah, that's a great question. So I talked a little bit about it already in terms of the continuum of normal development and how, some precocious children will learn to walk and talk at 14 months, and others really won't speak until they're about 2, and that's normal. And so some of what we see is a sort of a desire, shall I say, on the part of parents and pediatricians to wait and see, because often the concern goes away. And yet, now, with the heightened awareness of autism, I think people are taking the early signs and symptoms more seriously. And yet, still, I hear from parents frequently that they will bring something up with their pediatrician, and the pediatrician says, let's wait till the next visit, or let's wait and see. So I think that one of our initiatives is to really mandate routine screening for autism spectrum disorders as part of pediatric primary care. And there are lots of other people working on this as well, and I think it's really coming along as an important avenue for earlier detection. We know we can pick it up as early as 18 months, but it has to be by someone who knows what they're looking for. So there needs to be training tools available for pediatricians. There are some really interesting initiatives posting videos of children with autism that are searchable databases, so that if you see a 5-year-old child in your office that has communication delay, you can click on a video of a 5-year-old child with communication delay related to autism, and you'll be able to compare those to the child you see in your office to what you see on the video to help educate yourself. And the pediatrician's role would really be just one of referring on for further evaluation. And our attitude is, go ahead and refer. You're always better to over-refer than to under-refer. And the experts, the developmental pediatricians and the psychologists who are trained in diagnosis can sort it out. So as we push on that, I think that we'll see this mean age at diagnosis come down. And ideally, we'd like to see it down around 2 years when we know we can diagnose it reliably, and we then have the opportunity for early intervention. This is something that the nursing school is very interested in participating in, and we think that nurses have a real role in this area.
So then as a follow-up question, we do have a question about how nurses are involved, and specifically maybe here at Penn Nursing, diagnosis and maybe the ongoing care of autism.
So we're really on the cusp of launching some really exciting initiatives around that. We are launching this fall a postmaster's certification in autism for nurses who will then learn things like early signs and symptoms. They will learn diagnostic care, diagnostic management. They will learn how to integrate the care for these children across the many domains that they have care in. For example, speech and language, behavioral therapy, psychopharmacology. So these families are going from practitioner to practitioner trying to get the best care for their child, and we're developing a model where the nurse will act to integrate that care, and really we believe that the outcome for the child and the family will be far superior. There's now a mandate for insurance companies to pay for the medical care of children with autism, so we're hitting this at a very good time because insurance companies are obviously going to be very interested in seeing evidence of the best therapy and the best care. And we think that Penn Nursing can be a model for that.
That's great. This is Lisa again, and I just wanted to make a note because we did have one question about some of the studies and the papers you mentioned, and I just wanted to note on your screen now that there's two sort of boxes at the bottom of your screen. One says files, one says web links, and these are both additional resources, additional information related to Dr. Pinto-Martin's presentation. So you are welcome to either download those files or browse to the links that are listed there, and that's some additional information that might be of interest to you.
And let me mention another link while we're on that topic, because
Great.
I was talking about early signs and symptoms and moving the diagnosis down from the age 5.5 to earlier. And the CDC has a campaign. It's called Learn the Signs, Act Early. And some of you may have seen some of their ads that, that exist. They're really very nicely done. And on their website, the CDC website, if you search for Learn the Signs, Act Early, they have some really nice information about what the red flags for autism spectrum disorder are and what you should be looking at, when you should be concerned, and what you should do if you are concerned. So I highly recommend that for people who are interested in that issue.
Great. And now, while we're doing more questions here, I'll see if I can pull that up and add it to the web links that are on your page.
Okay.
So another question that came in is just sort of a general question, but what are your thoughts on early treatment and therapy? You mentioned that the average age of diagnosis now is up over 5 years, and ideally we would get it down to 2, be able to start treatment early. But what sort of treatments are available for early diagnosis, and what are your thoughts on those?
So another great question. It's absolutely key that treatment be initiated early, and we know from many studies that have been done that the earlier the treatment is initiated, the better the outcome. And the problem is that we haven't a lot of really well-studied options for treatment. So the primary intervention is a behavioral intervention. It's very, very labor-intensive. And yet it can be quite effective. And it's really training the child from a very early on age to reduce some of the behaviors that are associated with the disorder. So improve communication, improve social interaction, improve the exchange, so the give and take of social interaction, and to reduce some of the ancillary comorbid behaviors, the tantruming and the frustration that comes along with lack of communication. So early intensive intervention really does work. Families are entitled to it. Under the federal law, they're entitled to care for their children, and that can be one-on-one care in the classroom. It can be wraparound care that occurs in after-school hours. And the best results that we see are from families who embrace those interventions and really are doing them all the time with the child. It's just part of their life with this child. And intensive intervention for a child who's mildly affected can really reduce the symptoms to the point where the diagnosis may not be as relevant any longer. And I say that with caution because there is no cure for autism, but there is improvement that can be made in the behaviors and the characteristics. And I think that people need to understand the difference between those two. They also need to understand where their child is on the spectrum, mild, moderate, severe, and what their expectations should be about improvement in those characteristics. And again, this is where I think a nurse coordinator, a nurse integrator can help the family cope with the diagnosis, understand what services are available, understand what services are best, and help to integrate those services to maximize the outcome for their child.
Great. We have one more question here, just thinking a little bit about the fact that all of your work is happening here at Penn, Dr. Pinto-Martin. Can you talk a little bit about how, hopefully, this is an ideal environment to be doing some of your research, and what role interdisciplinary science and your connections with other programs at Penn plays in what you're...
That's a great question. It's absolutely critical. I think one of the reasons that Penn is such an exciting place to be for me with respect to autism research is that we are one campus. We have the medical school, the nursing school, and all the other programs right here on a contiguous campus, and we are very readily able to interact with one another. So I work very closely with individuals from the School of Medicine, Department of Psychiatry, from the Department of Pediatrics, from social work. There are lots of different individuals who are engaged in autism research and autism care, and they are scattered throughout this campus, and yet we can work together to make things happen. It's definitely something that our president feels very, very strongly about, this notion of integration across the disciplines, and she recognizes that in many different ways, including bringing professors in specifically with a goal to have this integration of knowledge. And she has a big initiative now, this is Amy Gutman, to bring in individuals trained in neuroscience, and clearly autism falls within that domain, and I believe that it will be even more energizing in terms of the research and work that we do related to autism spectrum disorders.
Great. I just want to, before I go to the next question, I just want to remind folks that we would love to have your questions, so don't be shy about entering any you have in the Q&A section on your screen, so we can address those with Dr. Pinto-Martin. So the next question that we have is, what can we as individuals, whether we have family or loved ones with autism or not, do to be advocates in this arena and to help as we move forward with research and treatment and diagnosis?
So I think that good information is critical, and there's a lot of bad information out there, and the web is unfortunately a great resource and also really a problem, because families who are concerned and anxious and in many cases desperate will go to the web to look for answers, and the information is not well screened. We know that. So if you know somebody who's looking for information, direct them to an NIH or a CDC website, or direct them to a place like the Children's Hospital of Philadelphia Center for Autism, where very carefully put together information can be disseminated. I think one of the biggest problems we have is people latching on to what they believe will be a quote-unquote cure, and then being profoundly disappointed when it doesn't work. Or conversely, believing in a hypothesis like the vaccine autism hypothesis and refusing to vaccinate their child, thereby putting their child and many other children at great risk for communicable diseases that are frankly much more devastating than an autism diagnosis might be. So I really think reminding people that information, good information, is really important in this age of information, and that they need to go to the right sources.
And I think that's a great it's a great suggestion. I know for any kind of ailment that you're suffering these days, it's all too easy to go on the web and find a lot of unsubstantiated information. So I think knowing where to go for that information is a great recommendation. Another question we have now is about the SEED study, and we have someone asking if you are still recruiting participants for the SEED study, and if so, for which groups, and maybe if not, if you could tell us a little bit about where you are in the process with that study.
Okay, well, I'm thrilled to say that we are still recruiting. We just have been refunded by CDC for another 5 years of the study, and a good portion of that will be continued recruitment and enrollment, and then we'll be moving into the analytic phase. So we are still recruiting. We're recruiting across all 3 groups. So again, those are children who have a diagnosis of autism spectrum disorders, and children who are completely typically developing, and children who may have some other neurodevelopmental condition but not autism. They must be between the ages of 2.5 and 5. And the reasons for that are because we need to have a consistent age group across all of the people that are, all the groups that are participating, all the other sites that are participating in this study. And we want the child to be young enough that we can access good information on the mother's medical history, that we can ask the parents information about their exposures and their background that will be reliable, because it won't have been too long ago that we're asking about, and because that is the age of greatest interest for this disorder. So 2.5 to 5, and born in one of these 3 counties, Philadelphia, Chester, or Montgomery County, born in and still residing there. So if the person who asked that question knows of somebody or is interested in further information about that, they can go to our website on the School of Nursing website, which will talk about how to access information about recruitment and enrollment.
Great, and we'll be sure to include that link when we send a follow-up email to the folks who are on the call today. So we're sort of coming to the end of our questions here. I just wanted to see, Dr. Pinto-Martin, if there's anything else you wanted to add, or if any of these questions have sort of spurred any other thoughts in you before we finish up.
I think the one thing that I just want to close with is this notion that although we are in the throes of producing good science, epidemiology is an observational science. It's not an experimental science. So we're not going to be in the lab and say, aha, we have discovered the cause for autism. We're going to be out in the field for many, many years. We've been in the field with the SEED study for 5 years now, and we still don't have an answer. And that can be very frustrating for people, and I understand that frustration, but I also want to encourage people to recognize the value of epidemiology and recognize that it is an observational science that takes a long time. We're looking at people the way they live their lives, and we're trying to tease apart the multitude of factors that contribute to a disease like autism and really make sure that we have good information. And so, the families who participate in our study are amazing because they know that they're contributing a day or more out of their lives, and it's not going to help their particular child, but they're doing it because they believe it will help another family and another child down the line. And that's really the spirit of this kind of investigation, that we have to recognize that it takes a long time, the information is slow to come, but when it comes, it is applicable. It really, we can roll out the information quickly, and it will mean something because it's talking about the way people live their lives on a day-to-day basis. So just to encourage people to be patient and to recognize the value of this kind of work, and we will come up with some answers. It's not going to be tomorrow, but it will be in my lifetime, I'm sure of that. So.
Well, thank you. Thank you. I think that's a great note to end on. And I want to, on behalf of everyone on this call and everyone in general, to thank you for the work that you do. And thank you for taking the time to share it with all of us today. I know I learned a great deal.